Okay, welcome. Glad to be with you. Those who are able to join live, watching on the recording. Famed host Glenn Grossman. As many know, he's an epidemiologist pursuing his doctorate in epidemiology at UNC Chapel Hill. Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. And can I add that other new piece of news to this intro, Glenn, or not yet?
No, not yet.
Okay. He has been involved, or you'll see, you'll soon find out. He has been involved in epidemiology forecasting and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs within the United States and abroad. As usual, all views expressed today are his.
Oh my.
Looking here in the United States and abroad.
Great. And Rebecca, can you
Glenn,
please—
before you do that, I'm going to mute everybody. So
Great.
If you have questions, please send them to me via the chat and I will, let's see. Why is this not working? Glenn, I think I need your help with the muting. It's not.
All right. Oh, did you sign back in again? Let me make you co-host.
There we go.
Okay.
Okay, so if you have questions, send them to me via the chat button at the bottom of your screen, and I will do my best to weave your questions into our conversation. And thank you to everyone who has sent in many great questions that are part of our conversation already tonight. Glenn, thank you for your hard work in building so many terrific slides. Okay, take it away.
Great. Thanks, Rebecca. So here, let's share my screen. All right, and let's start in the United States, which is not that. The United States is over here. All right, so here's where we are. The red line, first let me turn this off. Well, we can just look at the red line. Red line is the total number of cases. You see we've had a bunch of surges so far. The Delta surge is this last big one that we've seen. We were coming down, but now it started to flatten and to start to get a little bit going back up again. And we do know, we've talked previously, that we do expect that there's this seasonality component to it. So we do expect that this is going to continue to increase for a few months. We don't know exactly what the rate of increase is going to look like. It's probably going to be bigger a little bit over time as we get through the typical cold and flu season, peaking by around February. But we'll get into that. The yellow is the death rate per 100,000. Let me see. When you look over here at here's the big picture. This is from the New York Times. You can see that there's clearly a regional distribution of the spread right now. This is at the county by county level. So you see we have the typical northern, the northern part of the country is getting hit the hardest as the winter descend on the country. But we also see this remnant of this large swath of the United States, this sort of Midwest, that's also being hit pretty hard right now. When we look at a few other things, so we do see some rise, like so Minnesota you can see is rising dramatically. This is just spiking really high. When you look at a region by region, it corresponds to the map that we just saw. So essentially the green, the Midwest is rising very fast. Red is starting its seasonal uptick. Blue is the South. It's starting to go down, or it's been going down for a while, but it's sort of plateauing now. However, this time last year, around November, even though it was lower, it did start to rise again with as much of the rest of the country started having an increase just because of travel and other reasons. So even though it's low now, it could start rising again soon. And then also the pink here is the West, which is higher than it was last year, and we expect to go higher over the next few months. a few things that are interesting here. First, so this is a constant theme that the unvaccinated are doing far, far, far worse than the vaccinated, both in terms of the infection rate, as well as among those who are infected, the death rate for them. And so it's at every level. So people who are unvaccinated are more likely to get infected. Among those who are infected, those who are unvaccinated are more likely to be hospitalized. And among those who are hospitalized, those who are unvaccinated are more likely to die. So vaccinations are helpful at every step of the way. But now here's the key thing that I wanted to point to. So what we're looking at here are the trends, the 2-week trends. For the United States as a whole, so the graph I just showed you a second ago, you can see that it's starting to go up slightly, but some states are doing much worse. So for instance, New Hampshire has gone up over 100% from 2 weeks ago, Vermont 90%, Rhode Island 55%. When you look at the number of states that are increasing, it's quite a lot of the states in the country are actually getting better, are actually getting worse in terms of the number of cases. So the seasonality is increasing a lot. There are a bunch that are getting better, but the majority at this point are starting to get worse. And you can see that they're accelerating. Some of the states are really starting to accelerate more. When you look at hospitalizations, that also, so there's what, couple dozen states that are increasing in hospitalization now. There's always a much longer lag between deaths and hospitalization, particularly now as we've gotten better at treating people who are hospitalized. But the deaths are going to continue to rise. The daily average in the United States is over 1,000 people dying from COVID still right now per day. And what this means, I don't know if this was a separate question, but I thought it would be a good time to revisit this. So we've talked previously about excess deaths in the United States. We are about to hit, before the end of the year, 1 million excess deaths in the United States at the rate that we're going. And so again, the interpretation, this is the surges that we've seen in the United States. You can see that the typical year in previous years, you see that there's the seasonality to the death rate. Typically because of cold and flu and other things, heart attack and other things that are associated with the seasonality. You do see the seasonality in people dying. And so if you take, Rebecca, can you put people on mute again? And so if you see the peak.
Glenn, excuse me for 1 minute. If you could just make me co-host, then I'll do that.
Oh, absolutely. Let me do that. I thought that I did. Make co-host. All right. All right. How's that? Okay, good. So so here's what we're looking at. So if you look over here at the graph, you can see that it's highly predictable, the average number of deaths that we see. You can see that there's this white space. It's when you aggregate to the United States national level, it's highly predictable in terms of the number of deaths that you expect. And so the totals here you see are the totals that we've had over the last years. The orange line is sort of the statistically significant difference. And we use that so we can see, for instance, here was January 2018, there was a spike in some flu then. And so you can see that the red pluses made it statistically significantly more. But forget about the statistical significance. Just the average is simply what I'm most interested in right now. And so there's a difference between the orange and the average. The average, if you can imagine that the white space under the orange would continue here, then that's what the average would have been, this sort of like this imaginary line of where the white space began. And then the orange is the statistical significance. So the average is where the white space you would have imagined was, that's what we're looking at. We're at over 960,000. And based on the rate that we're going to exceed 1 million excess deaths on average by the end of the year. Based on statistical significance, that's going to be over 800,000. But again, the interpretation is not, it's a statistical thing rather than a common sense interpretation. And so the million excess deaths is more common sense interpretation of what you think about in terms of excess deaths. Give or take. So there's still some interpretation stuff that would alter the interpretation a little bit, but order of magnitude, 1 million is roughly where we're looking at. How does this compare globally? So first of all, that's a big number. That's big. So the COVID epidemic, and remember, these excess million deaths are with all the lockdowns, are with after the vaccinations, et cetera, everything that's gone down. If you recall, when we first had the lockdowns back in March of 2020, the reason that we locked down was because some of the models were suggesting that if we didn't lock down, that we'd probably have as many as 2 million deaths from COVID, 2 million excess deaths. And so the fact that we only have had 1 million is actually better than the worst case. I mean, so that's sort of what the lockdowns bought us and the vaccines bought us, is that we've saved all these other potentially million people alive. It's not quite, because that's if all the people were exposed that would have been exposed naturally. And so it's not quite the same interpretation. In reality, we probably saved hundreds of thousands of people over the last 2 years based on the lockdown and the vaccinations. But yeah, that's what we're looking at. Now, when you look globally, I'll just jump to this quickly. So here's the United States in green. This is our total percentage of excess deaths relative to our population. And you can see how we can compare to many other countries. So for instance, Peru had dramatically more excess deaths. Lots of parts of South America got hit really hard, but a lot of other countries did really poorly too. Parts of Europe did better than others. Asia tended to do better in general, but you can see there's wide variation. Despite the United States locking down early on, and despite our vaccines being available to us early, you can see that relative to a lot of other countries, the United States did not do amazingly well. When you look at where the excess deaths occurred, you can see that a lot of them occurred early on. So for instance, when we first got hit, that first wave in March and April of 2020, we didn't really know what was going on, but we locked down. But after that, we should have known better by summer of 2020, winter of 2020, and then even Delta when that hit, that we should have been dealing with it better, particularly because we had all the vaccines available by this last Delta wave. But anyway, this is what it is. We could have done much, much better. We could have done worse. So that is what it is. Let's look globally in general at where we are. I'm not going to go there. I'm going to look here. So you can see, if you look at some other, well, first let me look at the map. So now that we've started to see the change in seasons in the Northern Hemisphere, you can see that the parts of Europe and much of the Northern Hemisphere in general are doing worse. So here's where we were, say, a few months ago. This is July. And now as the seasons have changed, the Northern Hemisphere has gotten darker red. And so there's a lot of countries, Austria, here's UK, here's a lot of countries, Greece, that are doing quite poorly now. And so you can see relative in terms of the world, what's going on. You can see the Southern Hemisphere is tending to do better because they're approaching their summer months now, and it's getting warmer in the Southern Hemisphere. Chile is standing out here in South America, also up here a little bit. But let's look at some of these charts. So now United Kingdom is not doing very well right now in terms of infections. If you recall, they got vaccinated very soon. Their vaccination rates quickly exceeded the United States and are still a lot higher than the United States. Yet their infection rates have been high. It was surging, then went down a little bit, was surging, but it's still quite high, particularly relative to the United States. Here's the United States. You can see that that UK is doing quite poorly. Germany, you can see that they're just taking off. They're surge. This is the highest that they've had yet. And it's kind of this exponential curve that's going on. And yet Germany has also had a very high vaccination rate. France is just starting to take off. They're having this beginning of a surge here. Canada had a surge, but was coming down. Brazil, again, southern hemisphere, it's been going down. Australia going down, and India is doing well. They got hit really hard last year, and this curve doesn't really represent what happened in India very well because they were not testing very well. But if you look, so here, let's just look at UK. Let me get rid of some of these others. Australia, I'll get rid of Brazil, I'll get rid of Canada, I'll get rid of India, just so we can see a few case examples. This is the cases, but if you look at the death rate, you can see that actually the United States is doing worse than the others. So even though the United Kingdom has a much higher infection rate, again, here's the infection rate, here's the UK, here's United States. Theirs is what, like twice as high? Even though they're doing far, or more than twice, even though they're doing, so yeah, a little bit more than twice, even though they're doing far, far worse than us in terms of infections, it's actually not so bad when you look at the death rate. The vaccines are working. And so they're doing much better. A lot of the people who are getting infected are not having severe illness. And among those who do get severe illness, they're not dying quite as much. The ones who are doing poorly, again, are almost all the unvaccinated. They're much, much more likely to do poorly. Similarly, when you look, here's Germany and France, they're much lower even than the UK. Let's see, the other thing, there's a couple other things I was going to show is variants. So at this point, the variants are pretty much all Delta everywhere. When you look at the table, the key thing that I want to look at is, well, let's look at Delta. So this is the globe. If you just look country by country, virtually everywhere it's 100%. And I've been talking about this for months, that Delta would drive out all the other variants. And you can see that almost all the other variants that we've been worried about, Alpha and all these other variants, have now gone down to 0% in almost all the countries. So Delta is the key variant now. The other ones have gone extinct. There's still a few that we're looking at now. In some other countries, you can see that there's some others that haven't even been classified yet that might emerge here and there. But Delta is still so strong that it's tending to outcompete everything. So we're still keeping an eye on everything, but Delta again is still outcompeting everything. I think that's it. Was there anything else here I wanted to look at country by country? One thing is, so the forecast, I'll just show you. Here's the United States forecast. The green line is what's most likely. And so based on this current surge, based on what we're looking at, based on seasonality and other things, we're likely to see a peak around February or so, based on the way the surge is going in terms of infections, and then a similar peak a little bit after in terms of the death rate. And it's not going to be nearly as bad as we had last winter, but it's not done yet. And so that's what we're looking at. Part of it's going to be is in terms of what this is going to look like is based on how much masking and social distancing we see this winter and early spring. Last winter, we had a lot of social distancing and masking. If people reduce their masking and social distancing, which is what's very likely to happen because a lot of people have been vaccinated, the ones who've been vaccinated want to take the stuff off, and the ones who have not been vaccinated mostly don't care. So we're probably going to see a lot of masks coming off now and a lot less social distancing, which means that the numbers could actually be higher than what we even see in green. We could actually be somewhere between the green and the peach here in terms of the number of infections and the number of deaths. I don't believe we're going to see anywhere near the peak that is forecasted here, but we could see numbers start to elevate again as the seasonality comes in, particularly if we see a rise in flu. Let me pause this for 1 second. There's one that I wanted to share, one more website, and that is this one. So sometimes people have a question about flu. How common is flu? How bad will the flu season be? So last year at this time, the flu season, or not last year there was virtually no flu at this time, and that was because remember, last year at this time there was still a lot of COVID circulating, And so we still had a lot of mask wearing and a lot of physical distancing. People just were, organizations weren't meeting a lot still. Everything was still remote. A lot of businesses and organizations were all still remote. But 2 years ago, when you looked at the typical flu season, it really started around this time. So around middle of November, you had 1 to almost 2%. And then from there, it very quickly started to climb, so that by middle of December, you had 5-6%, or total influenza. This is influenza A, influenza B. So between the two, it was 2 to 3% at this time last year, and 2 years ago. It quickly climbed by middle of December to around 10 or 11%, and then reached its peak around middle of February, before it started to go down. But this year, you can see that we're in November, or by where we are here, we only have around 0.3% flu. So it's still barely any. So if you compare where we are now again, so this is so this is the full week, 0.3%, to where we were 2 years ago at this time. We had around 3%, so almost 10 times as much flu 2 years ago versus where we are now. Yeah, so a lot of people are still worried that we could have a big flu season, and it's certainly far too early to tell how bad this flu season is going to be. But it could be better than a lot of people are worrying. However, if it turns out to be bad, then it could be worse than some people are thinking, because we've lost immunity. A lot of people have lost this influenza immunity over the last 2 years. And so if it does start to spread, it could mutate and spread much more rapidly than would be good. All right. So we've talked about that. We've talked about the excess deaths. I'm just going to start closing some of these. We've talked about the Delta variant. We've talked about this data. Oh, let's talk about vaccines. Oh, no, before I do that, let's talk about pediatrics, and then we'll get into questions. There's so many good questions this week. So this is a really important question. One issue that we had is how much is COVID spreading around among kids? So if you look at the 3 subgroups, the solid line is age 12 to 17. The big dashes are age 5 to 11, and the dots are 0 to 4. So if you look here, right now there's like 10 regions. Region 1, 2, 5, 8, and 10 are the very northern regions. And so if you look at the percentage of people who are getting infected, you can see that kids age 5 to 11, it's really starting to spike. So region 1, again, which is the New England area, you see that it's starting to really take off. Part of it is because the 8 kids age 5 to 11 haven't been vaccinated for the most part yet. And so you'd expect that they'd be most likely to get infected because the vaccination rate is among the lowest. However, despite that, there's also this worry that they are getting infected more and that they will go home and infect their households. And so we have some slides to talk about that in a little while. But you can see in most regions, here's New Jersey, New York is region 2. Region 5 again is the Great Lakes areas that's starting to go up. Also, when you look at the kids who are a little bit older, 12 to 17, who do have higher vaccination rates, the numbers are still quite high. Look at region 7, region 8, there's a lot of 5 to 11-year-olds are starting to take off. This is disturbing, particularly when you look at where the 5 to 11-year-olds were previously. So like compare August 2020 as a percentage to where they are now, it's dramatically higher. Again, some of this is because of the vaccination rates, that they're just not this vaccine. The vaccines have only been available for kids for the last week or so, a little bit longer. But despite that, this rise is very dramatic. And so this is something we're keeping an eye on. Like if you look at region 3, Mid-Atlantic, this is just going straight up. But even region 4 and some of these that got hit earlier, if you look, so we just looked a second ago here, that you can see that where the distribution of the transmission is of the spread, you can see that the far south, this region down here, Florida, Georgia, they tend to be doing the best in the country right now. And yet, when you look at the kids, this is region 4, the kids in region 4 are still starting to spike again. And so the worry now is, will they start another surge? And that's a question. Maybe that'll be the first question we go into in a second. And so I'll put this on pause for a second because there's just a couple other things about vaccines I want to go into, but then we'll return to this. Just keep an eye. Here's region 4 spiking, just like the kids are everywhere else in the country. And so the question is, even though right now region 4 is doing so well apparently versus the rest of the country, will we expect in the next month or two that there will be another surge? But let me just talk about the vaccines real quickly, and then we will go from there. So here is the vaccination rate. This breaks it up by over time by age. So that this is the most recent by age, and you can see that so this is fully vaccinated. You can see that the people 75 and over, around 83% are fully vaccinated. People 65 to 74, 88%, and so on. Among people who are age 12 to 15, so they've been available to get vaccinated for a while now. Around half of them are fully vaccinated, and around so this is the question of the kids again. In the older kids, 12 to 15, around almost 60% have gotten at least their first dose. In terms of the kids under 12, so the most recent where it just has been available over the week, around 3% have gotten vaccinated already, which is astonishing. It's only been a week. We're at around 1 million kids under age 12 have now gotten their first vaccine dose over the last week or so since it's been available. And so that's great news. A lot of people are really rushing to get their kids vaccinated. That's great news. But so we're starting to go where we need to be. But having said that, when you look at the older people where the vaccine has been available for a while, there's still a huge amount of vaccine hesitancy. And among the total vaccination, you can see a lot of people, there's no excuse for a lot of people to have not gotten fully vaccinated by now. So Rebecca, with that, I'm going to turn it back over to you for questions.
Okay, Glenn, thank you for that deep dive, taking us around the country and around the world and answering so many questions. Let's dig a little deeper about the portion that you just spoke about involving children. And we have a great question that came in. Do surges in kids create surges in adults? Are kids infecting their parents and their households?
Yeah, that's a good question. So we've known previously that for influenza, for the flu, so virtually every year we see a huge spike in children before we see the surge in adults. And so this is really strong evidence that the kids going back to school or interacting with each other in the fall and winter, spreading it among themselves, they bring it home and then infect the households. And that's basically what's going on with the flu generally. So it's been a question, will this drive transmission for COVID? And so, because remember, last year around this time, a lot of kids were still remote. And so now the kids are back in school, what can we expect? And so there's some really good data in Europe. We've been following this in the US, but I like this data from Europe. England was among the last to vaccinate their 12 to 17-year-olds. And so when you look at so they're teenagers, when you look at the rates here and then compare it to the surge in teenage cases, you can see that the vaccinations in these other countries really was strongly associated with preventing the surges. But so we saw this massive surge in England among teenagers who were late to get vaccinated. And then, and even Scotland, comparing Scotland to England, which is both part of the UK, you can see that Scotland had this variation that they got vaccinated a little bit bigger. And you see that even that vaccination, even though it was later, had a big impact on reducing the surge in teenagers in Scotland. But when you focus specifically on the UK, you can see that the surge in teenagers was strongly associated with infecting the kids in the households and infecting the parents and all the different age groups across UK or across England. And so clearly this vaccinating the kids, there's a huge amount of accumulating evidence that vaccinating the kids prevents the surges in adults and in communities. So it is so important to vaccinate the kids. Remember, vaccinating the kids is helpful for the kids because it prevents severe illness. It prevents multi-system inflammatory disease, the MIS-C, and it prevents the long COVID in kids, as well as hospitalization and more severe disease. But in addition to helping the kids, it also prevents spread in the community and prevents other people from getting severe illness and dying. So really, it's a civic duty for kids to get vaccinated in addition to protecting the kids and caring about the kids themselves. So this is really critical. That the evidence has become quite clear at this point. All right, Rebecca, there's a ton of questions. So I'll try to go through them a little bit more rapidly.
Okay. So continuing on the discussion here around kids, many people are now very excited to get their kids vaccinated. And so now the question is, when can the masks come off in school? What's your thought on that?
All right, so this is a tough, so first I'll answer your question with more questions. And the question, so here's how epidemiologists think about this question. When can kids take off their masks? So if we put our epidemiologist thinking hats on, the question we ask is, what criteria should we use for deciding when kids should take off their masks? And so let me go through a list of possible criteria, because right now we don't have any one set of criteria that we know are best. So for instance, should kids be allowed to take off their masks when enough kids have had a chance to get vaccinated? Maybe we'll say, well, it doesn't matter how many kids have gotten vaccinated, as long as a certain amount have had a chance to be vaccinated, then everyone can take off their masks. They had their chance at their opportunity, and so that's it. And so if that's the case, then maybe 8 weeks from now. So remember, once you get the first dose, then you wait a month, you get the second dose, and then 2 weeks later, you're fully vaccinated. So maybe 8 weeks, and that's enough. And so that's one answer. Some people, so if you recall, I've mentioned previously that polls have been consistently said that roughly 1/3 of parents have said that they will get their kids who are 5 to 11 years old vaccinated immediately. 1/3 will wait and see, and 1/3 will not do it at all. Well, for the 1/3 who want to wait and see, if we say 8 weeks is all they have, then that's not a lot of time. That's only 2 weeks to wait and see, or else they're in deep trouble. So maybe for those people, the real world evidence will be available by around February. And so what I mean by that is that if we have all the people who are getting vaccinated now, all the kids getting vaccinated now, age 5 to 11, by February, we'll have information on millions of these kids aged 5 to 11 to look at how safe it actually was in the real world and how effective it actually was in the real world. So that real world evidence, those studies, will likely be released by early February at the latest. And so then maybe by then, so then 8 weeks after that's released, we're talking about March, April, would then give them an opportunity for all of them to be vaccinated. Alternatively, maybe they're not going to be happy until they have an opportunity to talk to their pediatricians. And so on average, the recommendation is that kids see their pediatrician around once a year. So age 5 to 11, they should see their pediatricians at least once a year. So maybe we should have an opportunity 1 year from now. So, or 8 weeks from 1 year from now. So so every single person has an opportunity to talk to their pediatrician and then start the cycle. So depending on the criteria, then these are different dates that you would say, okay, well, that would be a good chance for everyone to have a legitimate chance to be vaccinated. But here are some other criteria that people are looking at. Maybe when the percentage of a school has been fully vaccinated, that's sufficient. So forget about these other things in terms of people waiting. Let's say maybe 50%. In some parts of the country, they're saying, well, if 50% of the school the faculty, staff, and students, if 50% of the whole population have been vaccinated, maybe that's a sufficient cutoff. Other people more commonly seem to be saying maybe 70 to 80%. So if the whole population of faculty, students, and staff hit a threshold of 70 to 80% are vaccinated, then maybe that's good enough where everyone can take off their masks. The problem is, then that has to be something that the schools verify. And that's a whole huge administrative process, finding all of the vaccination cards for all the faculty, staff, and students. That's a big burden on them. So easier than that would be looking at municipalities. So maybe by zip code or by county. And so maybe instead looking at, because that I've already shown you, we have this great data from all these different places. You can just look at a map like this. This is New York Times. Well, here you go. It says every county in the United States, and you can see exactly what the vaccination rate is. And so maybe this would be much easier than looking at people's individual vaccination cards. And so immediately that would be a universal way of looking. And so maybe that's one way to do it. And so maybe when a county or municipality has reached 70 to 80%, then that would be a reason for everyone to be able to take off their masks in the schools and in other places. Maybe it's at the state level. Some states are saying, okay, if the state has reached 70 to 80% vaccination rate across the whole population, that's good enough. Other places are saying, well, forget about all these things. That's too complicated. Let's just say January 1st. Maybe by January 1st, it will have given everyone enough of a chance to get it who wants it. And so people who have not gotten it, that's on them. So January 1st we'll have as the cutoff date. And I think some localities are saying that. Other places, so right now we've looked at all the vaccination rate as one strategy. Then we've just looked at this as just the date, just a flat cutoff date, January 1st. Another way of looking at it is the caseload in the different municipalities or states. So maybe we just looked over here at the hotspots. We've been looking here. Maybe if the hotspots stay high, then that's a reason not to take off the masks, even if the vaccination rate is high. Because remember, even in places where the vaccination rate is high, if the surge is still going on and the unvaccinated people are getting infected, then that still puts the vaccinated people at risk. So maybe that's a good reason to still continue wearing masks in some of these hotspots, even if the vaccination rate is high, just during the cold and flu season this year, where this is the last year where we really have to worry about that potentially. So maybe in that case, states like Florida, which have a very low surge right now, even if their vaccination rates are low, maybe that would be a reason to not wear the masks because the surge is so low. Whereas in other places where the vaccination rate is higher, if the surge is higher, then you'd still wear the masks. So that's another thing. One other way of looking at it is the hospitalization rate instead of the regular infection, just simply looking at hospitalization rate. We've talked a little bit earlier that as the vaccination rate goes up, even if people are infected, they're much, much less likely to be hospitalized. So maybe all we really care about is hospitalizations, because remember, we don't want our hospitals to overflow. And so that would be another criteria that would be maybe the most critical one that we're looking at. Two other things to think about are, should the vaccinated unmask, but unvaccinated keep masking? In some parts of the country, well, in the country, we haven't really looked at this yet. In some parts of the world, this is actually a thing. So for instance, Austria right now is about to lock down, but only locking down for their unvaccinated. For the vaccinated people, they're saying, okay, you can go and enjoy life, but unvaccinated people have to lock down. I don't know if we'll do something like that in the United States. I think that will be hard to enforce, but that's another criteria or another strategy we can think about here. And then finally, do we need to decide what criteria? Can we just take a wait and see approach? So when you look at different bodies, right now there's not one universal body deciding on this. Right now the CDC is saying, let's take a wait and see approach, whereas some states are taking some of these other approaches, some of these other criteria, and some public health organizations are recommending other criteria, and there's no agreement on what is best. I think personally, by January 1st, once most people who want to be vaccinated have been vaccinated, it's going to be really hard to require people to continue wearing masks when so many people have gotten vaccinated. I don't know about you, but for kids in our lives, age 5 to 11, I know that a lot of parents, when those kids got their first vaccine, it was like a sigh of relief, a breath of relief. And once they're fully vaccinated, a lot of parents are just going to want to have their kids take the masks off. Next semester, just take the masks off. So this January 1st threshold might just be what is used. It's probably going to vary on a case-by-case situation. Like I said, if come January or February, the surge is still happening strong and is much stronger in some of these northern states, that could be a reason why we want to have the masks on for another couple months. So all of these criteria have benefits and burdens. So we can revisit this in later weeks. Right now, I have no set, I'm not going to put my guidance on which criteria I think are best. I can see benefits and burdens for both. I think that already a lot of schools in the United States are already taking the masks off. So I think that by January 1st, a lot are just not going to mask. Some might, but there's benefits and burdens for all of these. All right, Rebecca, next question.
Okay, thank you, Glenn. So it sounds like more to come, but we thank you for sharing the different vantage points as always. So I'm having a little bit of technical difficulty, so I'm going to ask some of the great questions that are coming in live. Rachel has asked, do we feel that these surges maybe are due to the effectiveness of the vaccines wearing off over time, and maybe not people not getting their boosters, or people unsure of when to get boosters?
Yeah, that's a really, really good question. If we look back over here, oh, let me come back to this in a second, the kids vaccines in a second. But if we look over here, here's the rate of vaccinations. Again, we just saw this just a little while ago in terms of when people were getting vaccinated. You can see that among the older people, this is the dark purple and pink, they were largely, or the percentage of them that are vaccinated, they mostly hit this point where the vast majority of them were vaccinated by around May. And so now in November, it is around 6 months after most of them have been vaccinated. So you can see that a lot of that might have been wearing off. In contrast, people at younger ages have been getting vaccinated more recently. So a lot of them have more active protection among the younger ages. But you're right, among some of the older people, some of it has been wearing off. I don't see here the booster. Let me look at booster. Whoops. States, here's the tracker. So among people with the booster doses, around a third, a little bit more than a third of people over the age of 65 have now received their booster. So those people presumably are much more protected, but there's still a lot of people who have been fully vaccinated but have not gotten their booster, almost 2/3. And that's a lot. So part of it is to deal with that. But still, when you look at some of the rates of who's getting, do I have that here? Is this vaccine effectiveness? I don't know if I have it here. No, I don't have a good picture of it here. When you look at vaccine effectiveness, I just showed it earlier, I think. The vaccines are clearly very, very effective, and so a large percentage of people who are being hospitalized are actually the unvaccinated at this point. So it's making a massive difference. All right, Rebecca, let me just jump in here before we go on further. This is the question of comparing the COVID vaccine to other vaccines common in kids, because this is going to come up as a question for mandates. Right now, it's not mandated for kids, but look at how there's other common childhood vaccines. Look at the criteria that we're using. So hepatitis A, on average, before the vaccines became mandated, hepatitis A killed 3 kids on average per year, hepatitis A. And that was enough for hepatitis A to be mandated as a vaccine. The I can't pronounce this very well, 8 kids per year. Varicella, this is chickenpox, 16 kids per year on average died. I mean, a lot more for each of these were hospitalized, and we'll get to that in a second. Here's down this below. Rubella, 17 per year. Rotavirus, 20 per year. And in contrast, COVID-19, and this is despite all of the lockdowns, despite all of the mask wearing and social distancing and everything, 66 kids were killed. And so it might not seem like a lot, but when you compare it to the other vaccines that are mandated, this is a lot. Now, when you compare it to the hospitalizations, again, very high. Hepatitis A, less than 1. Chickenpox, 4 to 30 on average. That's right at what we're looking at with COVID-19 in terms of the rate of hospitalization per 100,000. Influenza varied per year between 30 and 80 per 100,000. But again, this is not apples to apples because we never had the lockdowns for influenza like we did for COVID-19. We never had the massive mask wearing, the remote learning, etc. So it's not apples to apples. But given this order of magnitude, it is 100% completely in the ballpark that we're looking at, completely reasonable to expect that there will be mandates for kids, because it's totally in line with what we're seeing for these other commonly mandated vaccines. So I'll leave that there. All right, next question.
Okay, thank you, Glenn. Okay, so many folks are asking, I want to know what my immunity is. How can I know? Where do I stand vis-a-vis this whole conversation? So should folks get antibody tests to know their immunity? How can we know what it is?
All right, so the short answer is no. Your antibody levels don't tell you necessarily what you think it tells you. So first of all, so let me review this. We've seen it a couple months ago, I think, at some point. But basically, this is the way a normal infection looks. So you get the first infection or vaccinated, but in this case, we're looking at a first infection. Your immune system responds in what's called the primary antibody response. In addition to the antibody response, you also have, which are what we also call immunoglobulins. There's different types of immunoglobulins. There's also T cell responses and other things. The immune system is very complicated. There's a lot of different responses. Over time, this starts, so this is days of exposure. At some point in time, it starts to go down. And at some point, it goes down below the detectable limit for many infections. And so that's what we're seeing for COVID-19 among people who are previously infected or vaccinated. At some point, it will go down below the detectable limit, but your body retains a memory of the antibodies, a memory of the infection. And so when there's a repeat infection, so if someone was first infected or first vaccinated, once there's a repeat infection or a first infection after the vaccination, then the body is much more rapid. So if you see the slope here, it's a slow slope, but they're much more rapid to have an antibody response, with the secondary antibody response. So even though your antibody levels might be undetectable, it might be sufficient to prevent any severe disease or hospitalization. So not detecting antibodies does not mean that you're not protected. And so it's not a good way to know. It could mean that you're not. So for instance, if someone's over the age of 70, they have a poor immune response in general, maybe they have other comorbidities going on. If their antibodies go below the detectable limit, then maybe that would be worse than a 30-year-old whose antibodies go below the detectable limit. But just having antibodies go below the detectable limit does not mean your antibodies are not, that your immune memory has disappeared. And so that's really important. So we're not recommending that people get antibody tests because it really doesn't tell you what you think it tells you. That's a critical thing.
Very helpful. So let's jump from there to super immunity. Can we derive any data from that chart?
Yeah, that's a really good.
More about super immunity, or is that something entirely different?
No, this is a good segue. So there's basically different types of immunoglobulins. And so this is a good chart to describe this. And let me make this the top one. All right, so basically immunoglobulin G tends to take place, this is what vaccines stimulate the most. It takes place the most in our bloodstreams. And so this is what we trigger the most. We also trigger a little bit of immunoglobulin M but it's primarily an immunoglobulin G, this IgG response with vaccines. In contrast, with vaccines, we have much less IgM response, virtually no IgA response. So IgA, immunoglobulin A, we mostly find it in mucosal tissues. So that means in the mucous membranes of the nose, of the mouth, the digestive tract. You can see here's IgA here, whereas IgG, IgM, IgE, and IgD are in the blood, in the circulatory system. IgA is in the digestive system and the mucosal membranes here in the respiratory system. So IgA, the benefit of IgA is it prevents infection. Because recall, if someone is infected, the first place they're going to be infected typically is their nose or their mouth or their lungs when they breathe it in. The vaccines, because it doesn't trigger immunoglobulin A, it doesn't do as good a job at preventing infection in the mucosal membrane. It does a little bit okay, but not very good because it doesn't trigger immunoglobulin A. In contrast, natural infection prioritizes immunoglobulin A because that's where people who are naturally infected, that's where they get hit first. So they tend to have a higher IgA surge, immunoglobulin A, and maybe not as a robust immunoglobulin G response because it's not as precise immune response as we've created for the vaccine. And so because of that, when we talk about super immunity, really there is this benefit for people who have both vaccine-induced immunity and natural infection. Because people who have both have the full complement of immunoglobulins that are ready to then attack a new infection. So there really is an advantage. Now, this doesn't mean that people should go out and have COVID parties. Like we sometimes had chicken parties decades ago for kids. That doesn't mean that people who are vaccinated should now go and have COVID parties. But what it does mean is that people who are vaccinated and have been infected really are in much better shape than people who have either simply been infected alone and not vaccinated, or vaccinated and not infected. One thing we can say for sure is that people who have been previously infected and not vaccinated should definitely get vaccinated because it does give them this super immunity. It dramatically, and in real world evidence, we're seeing dramatic differences in terms of people who are hospitalized, where people who are previously infected and not vaccinated are at least twice as likely to be hospitalized if they're newly infected and reinfected versus people who are previously infected and vaccinated on top of that. They're also an order of magnitude, at least that amount, maybe not an order of magnitude, but at least twice, probably more, a lot more than that. In fact, I do have data on that. A lot more likely to be infected. So remember, reinfections are somewhat common. Even after people are vaccinated, a lot of people are still infected, but the reinfection should be less based on this chart that I just showed you. Let me just come back up here. The reinfection should be not as severe because we have this immune memory. However, among people who are naturally infected, it's not nearly as good a secondary antibody response as people who are vaccinated. And again, people with the super immunity, it really is super immunity. It really is effective and is much more likely to persist, to be much more persistent. All right, Rebecca, I see we're at time, but let's ask a couple more questions because there's so many good questions. In fact, one of them is deer, and then you can ask another question outside of the deer question.
Just before you get to the deer question, we've had a couple people now ask, and thank you, Sandy. I'm sorry, I'm not calling on folks to ask questions tonight. I have a little bit of a technical difficulty here, but going back to super immunity, kind of piggybacking on that question. So does the vaccine eliminate the risk of long COVID? In other words, if somebody is vaccinated, then they are infected or they receive positive results. Does having the vaccine eliminate the risk of long COVID?
So that's a really good question. So among people who are vaccinated, it dramatically reduces the risk of long COVID. First, the first way it reduces it is by reducing the risk of people getting infected in the first place. So once you're vaccinated, it dramatically reduces the risk of infection. So that is a good way that it reduces long COVID. But then among people who have breakthrough infections, among those people, it also reduces different aspects of long COVID. So it reduces some respiratory, some heart inflammation. It reduces a lot of different aspects of long COVID. Some things that are unclear about are psychiatric issues. So for instance, anxiety, depression, but the studies are still unclear because right now the one I'm looking at here, I'm not going to go into the details, but the way it was designed, it was just a preprint. It could have been that people who had more anxiety were the ones who are more likely to get vaccinated. So just because vaccinated people are more have more anxiety if they have long COVID, doesn't necessarily mean it's long COVID. But these other key things that you're looking at in terms of respiratory, in terms of fatigue, there's a statistically significant, substantially less likelihood of having many long COVID symptoms if people have breakthrough infections.
That's good news. We'll take it. We like when you give us good news, Glenn. Let's move back to the piece about deer. What are we seeing in deer?
All right, so I'll spend just a few minutes on this and then we can call it a night, unless anyone has any last minute questions. But so let's talk about deer. And this goes back to this larger question of even COVID-19. Where did it even come from? SARS-CoV-2, was it from the lab in Wuhan? Was it from animals? So we are seeing spread in deer. A recent study demonstrated that up to 80% of deer sampled from April through January, so April 2020 through January of this year, were infected in some parts of the country. And so that's huge because the reason that this is so important is that this effectively means that it spread 50 to 100 times more in the deer than it did in the people living in Iowa at the time where the deer were. So that means two things. Oh, and so there's a couple parts here. One is that the different variants, if you remember, there were lots of different variants circulating. The variants in people were showing up in the deer, which means that people were frequently infecting the deer because the variants were emerging in the deer, and we don't know why. Was it because hunters were getting close to the deer and spreading it somehow? We know that it's not very effective to spread COVID or SARS-CoV-2, the virus, in outdoors environments. Yet, how were these deer getting infected? Could it have been in waste of some kind getting thrown out? Could it have? We don't know exactly how these deer were getting infected. There are currently around 38 million deer in the United States, many more deer around the world. And we haven't been looking at these deer to see how many have been infected. The problem is, as limited as our resources have been in public health in general, we've barely scratched the surface of looking at SARS-CoV-2 around the world in natural animals. And so, for instance, so first, let me say why this is important. I'll get to the other animals in a second. So what we don't know yet is whether deer can transmit the virus back to people. We can see that the deer transmit it way, way better to other deer than people transmit it to other people. So as much as the Delta variant is SARS-CoV-2 on steroids in people, this is like the Delta variant on steroids. I don't even know what the equivalent, steroids on steroids for deer. It's orders of magnitude more common, 100 times more likely to spread, is massive. We're talking about massive spread here, virtually universal at this point. This was 80% spread in deer by January of this year. That was even before the Delta variant became common. Now that Delta's, I don't even know whether Delta has the same effect. The big question here is if deer can then transmit it back to people. And the reason that becomes important is that you've heard of the bird flu pandemic or the swine flu pandemic. If new variants emerge in deer, because it becomes, now that it's endemic in deer, it's essentially now established. There's no way to get rid of it unless we were to somehow vaccinate all those 38 million deer around the wild, which would be extremely, extremely hard to do. So now that it's endemic in deer, if it mutates over time, then that means that it could cause new mutations that then come back to people and then cause hunters maybe that get exposed who are near deer, or other people who come into contact with deer could then get new variants of COVID that can then start new pandemics because our vaccines and our previous immunity cannot respond to it. And so that is a worry, and that's why we're following this. But now that we're talking about this, remember what other animals we've already seen over the last year that we found have been infected. So we found dogs can get infected. We found rats can be infected. Remember, minks were infected months and months ago, to the point that millions of mink were killed in order to avoid, because we found that it was spreading and mutating in mink populations in different countries around the world where they had mink industries for mink coats and whatnot. And so they were killed. Millions of these animals were killed to prevent a mink COVID new pandemic emerging in people because of the variants that were emerging in mink. So now there's a lot of animals that we've started to see. In fact, here's some others. So we've seen pet cats, dogs, ferrets. We've seen in zoos, larger cats like these leopards that we just saw here, where 3 leopards just died, otters, primates, and now we have the deer in addition to the mink farms. Here's an interesting study that was published back in September that I'll just look at briefly. And this was a theoretical study, simply looking at animals' genes of who was likely, or rather which animal species were likely to be able to get infected with SARS-CoV-2. And you can see that among those with very high risk, there's different primates and some various different animals. But the ones that we're seeing now that we just listed, they're on the high list. But there's a lot of other animals on the high list that we haven't been reporting yet in the real world. We don't know yet in the real world that they can be infected, because how are we even going to tell? So for instance, here, you might notice porpoises, whales. We don't know who's out there right now testing whales in the oceans right now to see if they have COVID-19. Could they? Yeah, COVID-19, just the simple virus particles have been spreading like crazy all around the world. It's in sewage. It's all over. We don't know how deer are being infected. It could be through sewage. And if it is through sewage, then guess what? It could be that we have porpoises, whales, and all these other animals that are now getting infected too. We have no way to know. Right now, there is no one out there systematically looking at any of these animals to see which of them are getting infected with COVID-19 or SARS-CoV-2. This is very problematic. Right now, this is very high and high that I've showed you. There are a lot that may not even be very high or high, but that are medium. And in fact, when you look at those on the medium list, that's where mink and some of the others are that we looked at. But on the medium list, we're looking at things like squirrels and other things that are very common. No one right now is out there doing a systematic study of squirrels for SARS-CoV-2. So this will be something that we're going to need to be paying attention to. And this is not the last that we've heard about this, because this is something that's disconcerting. But the reason that this comes back to why epidemiologists, I've talked previously of why epidemiologists are more skeptical of the Wuhan hypothesis, of the lab release theory. And that's because the SARS-CoV-2 virus is spreading so much in these other animals. So for instance, deer, there are plenty of deer in China. No one's been looking at them. In fact, remember, we've heard about the wet market in Wuhan. It's totally plausible that there were live deer who were infected with SARS-CoV-2 who ended up in Wuhan. And that's what started this whole thing. We don't have any way of knowing right now. But the fact that all these other animals are being found with SARS-CoV-2 means that we really are just scratching the surface here. This is something that we're going to have to keep on paying attention to, because it's spreading more and more.
Oh, goodness. We don't like this news. Can we go back to the good news from your other slides?
Well,
I'm just going to ask on behalf, Sandy had a really good question about the deer. Are they dying at a disproportionate rate? Are we noticing greater deaths in these deer than usual?
I don't know that anyone knows the answer to that. So right now, the way that we know these deer are infected is that people go out and take saliva samples. The problem is, if you have a dead deer, we don't know what they died of. For instance, if they were very few deer die of old age. I don't know the specifics, but they probably get hit by cars. If a deer is suffering from COVID, we don't even know if they get sick. Maybe they just get infected, they pass it along, but they're asymptomatic. If they do get sick, then maybe they're more likely to get hit by a car because they're just walking in the street and are not paying attention and so maybe they're just dying and getting hit. We have no idea. And so all we know right now is how prevalent it is. We have no idea how lethal it is yet. We do know in some of these other animals, for instance, in zoos, they keep good track of what animals are getting ill from among those who are getting infected. And we do know that other animal species like leopards, like a lot of these other animals, are having severe disease when they do get infected. Some other animals, not so much. It varies by species. This is a point. We don't have good surveillance. As bad as the surveillance is among people, it is orders of magnitude worse when it comes to animals. We just don't have a budget to go out and surveil all the different animals that exist in nature.
All right, so it sounds like more to come on this topic as we move from this pandemic to an endemic. Yes?
Yeah.
Okay, so thank you, Glenn. You've covered a lot of great data tonight. When are we meeting again?
Yeah, so that's a good question. Do you want to plan for 2 weeks from today? So it's currently the 14th, so we'll say the 28th. It's after Thanksgiving, Sunday night at 7 p.m.
Sunday night, 2 weeks from now at 7 p.m.
November 28th. Sounds great. So hopefully we'll have more good news to report at that point. We'll have a lot more 5 to 11-year-olds who have been vaccinated. Anyone listening to this, there is no excuse not to get vaccinated. This is one of the safest and most effective vaccines in human history at this point. Already, over 4 billion people with a B around the world have been vaccinated with any of these COVID vaccines. So if there were any severe side effects, we'd have seen it already. If the effectiveness, we already have a really good idea. For over 4 billion with a B have had at least one dose. Over 3 billion with a B have been fully vaccinated. So there is no excuse at this point. There are very few medical therapies of any kind where over 3 billion people around the world have taken it. So we know more about this vaccine, honestly, authentically, than we do about many other medicines out there and many other vaccines. So everyone at this point, go and get vaccinated as soon as you can if you have not been. And get the booster if you're eligible. Great.
Glenn, as always, we thank you for being our resident expert. How lucky we are to have you as our tour guide. Thank you for sharing your vast knowledge with us. We are so, so appreciative. Everybody stay healthy, stay well. Happy Thanksgiving, and we'll see you in 2 weeks.
Thanks a lot, Rebecca. Thanks, everyone. Have a great 2 weeks. Bye-bye.